everyone. So today's topic is reduced GCS and how to go about assessing and dealing with a patient if you're called to this situation. So objectives: understanding the components of the GCS, identifying common causes of reduced GCS, and then developing a systematic way of approaching a patient if you are called to someone with this question, and then basically forming a basic management plan depending on the clinical findings. So just going through definitions and just recapping things that you should all know. GCS is just used as an objective measure to look at the extent of impaired consciousness, and it can be used across every kind of patient. There's 3 components to it. You've got your eye, verbal, and motor responses. And then the scores will add up together from a minimum of 3 up to 15, and a lower score indicates a more impaired consciousness. So it's widely used in emergency settings. It's a way of quickly assessing someone's conscious levels, and also helps healthcare providers just make decisions about treatment and escalation plans. So just looking at the ranges in terms of the numbers, over 13 is considered a mild impairment, 9 to 12 are moderate, and under 8 severe. And one general rule that we always think about is if GCS is 8, intubate. So the idea is you're worried about their airway. So just going straight into a case. So ED have bleeped you and asked you to review a 45-year-old male who's been brought there by an ambulance after being found unresponsive at home. His partner reports he was complaining of a severe headache and nausea earlier in the day. There's no history of trauma, and on examination, his GCS is 8. And I've given you a breakdown here. So he's opening his eyes to pain. He is responding, but only making incomprehensible sounds. And his motor responses are 4, so he's withdrawing to painful stimuli. So just breaking down the GCS score here and actually looking at what you score for each component. As you become more familiar with it in your practice, it will become easier to be able to use this. It can be a bit hard initially when you're trying to work it out in your brain. But yeah, eye-opening. So if it's spontaneously eye-opening, they'll score a maximum of 4, and then it's reduced whether it's to verbal or painful stimuli. Verbal responses wise, it's whether they're oriented and kind of having fluent conversation versus confused or making inappropriate words or not responding appropriately, or just incomprehensible sounds, grunts, moans, and the like. Motor response-wise, it's whether they're obeying commands without kind of any issues. If they're localizing to pain, so they're trying to reach towards where you're applying painful stimuli. If they're withdrawing from the plane, or then you've got decerebrate and decorticate, and then decerebrate postures. So easy way of remembering those is they might flex to a painful stimuli, or they might extend to a painful stimuli. And that all relates to whereabouts in the neural circuits their responses are arising from. That gives you a total score then. The lowest you can score is a 3, because if you're not scoring for any of those domains, you still get a score of 1. So looking at causes, this is one of the mnemonics, just going through the vowels of the alphabet, A, E, I, O, U, tips. And we've got them all listed here. So alcohol and drugs can reduce GCS, seizures and seizure activity. Insulin is a good one to remember. So hypo or hyperglycemic states, they're both important, can both present differently. So it's always important to check your glucose when you're doing an A2E assessment. Overdoses, so it kind of links to the drugs, and hypoxic states. Uremia, trauma, infection, psychiatric and poisons. Again, it's similar to the drugs, and stroke or shocked patients, with severely shocked patient in septic shock or any other kind may result in an impaired conscious level and a reduced GCS. So when you're taking a history from a patient in this kind of situation, it's going to be very hard if you've arrived and your patient does have a reduced GCS and isn't responding appropriately. The key things you need to really get out are the past medical history, their drug history. So again, going back to this slide, you're looking at whether they have any medications that might be causing this. Are they a regular opioid user? Could this be opioid toxicity? And looking at their regular medications, do they take insulin? Are they diabetic? And that kind of fits into the past med history as well. Have they got a previous history of surgery or trauma, any head injuries or previous neurosurgery? And then what's happened preceding the events of the kind of drop in consciousness during and following, if they are now awake and responding to you when you get there to assess them. But again, like we've got there, the important thing here is getting a collateral history, because in a trauma setting or an acutely reduced GCS patient, you're not going to be able to get much of a story from them. In that situation, you might want to ask the nurse who's been looking after them, or the doctor who clerked them in if it's in the ED, or try and get hold of a family member after you've done your initial urgent assessments and started clinical treatment. So examination wise, in the trauma setting, again, you'll want to be doing a primary and a secondary survey. Normally, if it's a trauma patient coming in with a reduced GCS, there will be a big team there in ED helping you, and there will be a trauma lead who will assign different roles. But just going through what that kind of involves, and what happens is you will initially do a primary survey, looking for any, and that is involving looking through your A2E, making sure that there's no urgent clinical urgent clinical issue that needs addressing. And then the secondary survey is done following that period, looking for any other bony injuries or musculoskeletal problems. And in this case, for a reduced GCS, you will always want to do a neurological exam. This might be more focused in the acute setting. Again, it's not going to be possible to really appropriately assess the power of a patient's upper and lower limbs if they're reduced consciousness and not listening to you. But the more focused things, you would definitely want to look at the pupils, see if they're reactive, if there's any change in pupil size. If there's a change in tone, they could be having a subclinical seizure, and you haven't picked that up yet. And again, obviously, GCS forms a part of that neurological score and exam. So in this patient, like we said, there's no known history of trauma. His GCS was 8, and again, just recapping what that was for, he's scoring E2, V2, M4. So, examination. You assess the patient. The airway is patent still. You can hear them breathing. They've still got good O2 sats on the monitor. You listen to their lungs, equal and good chest expansion bilaterally. Heart rate is 74. Blood pressure is 107/74. They're a bit dry. The cap refill's normal, and the heart sounds are normal as well. Pupils are equal and reactive still. They're quite drowsy though. GCS is 8 and their BMs are 6. So you've ruled out hypoglycemia as well there. Temperature of 37.2, so not acutely running any fevers. So nothing kind of staring out at you yet, apart from the fact that they're still drowsy and their GCS is obviously very low. So you're quite concerned. So investigations then in this situation, you'd urgently want to get some bloods off, and you're looking for all the usual bloods that you normally do. So the full blood counts using these LFTs, bone profile, clotting, plus minus a group and save in this acute setting, in a trauma setting when they've just come in. You're looking for infection markers, you're looking for the calcium on the bone profile, anything off on their clotting, and group and save will just be if they are a surgical candidate or if they have need for surgery, or even giving blood products further down the line. Next thing that you'll want to consider early on is imaging. First line tends to be a CT head to rule out intracranial hemorrhage or stroke. Sometimes if that comes back with nothing acute, then you can consider doing MRIs, but that again will be under senior guidance normally. And then further down the line, you'll also want to consider lumbar punctures. However, that's again, it's going to be much further down the line. You always want to image first because you want to rule out any contraindications to an LP. And you're just looking for infections there. So you won't necessarily do that in the acute setting. So differentials wise, just kind of going through some teaching of what can cause a reduced GCS and looking at it specifically from a neurosurgical perspective. So you've got traumatic brain injuries, any trauma patient coming in secondary to an accident or a fall of some kind. Got different forms and kind of got them listed here. So feel free to pause and have a read through these things. Just refamiliarize yourself with the different bleeds and the differences between concussion, contusion, and hematomas themselves. It can be different kinds of lesions can cause this, depending on where they are in the brain and any structures that they're affecting, and that can cause aberrant activity and in the form of seizures, which can also impair GCS. Hydrocephalus is another one that could be a congenital issue, or it could be secondary to a different pathophysiology underlying that's going on. So again, it's a case-by-case analysis, really. So here's an image. Again, the most common and kind of useful things to know, I think, is about knowing the difference between an extradural hematoma and a subdural, and it's just remembering the shapes there. So you can see that there's a